I just want to thank everybody for joining us today for PQMD's Pillar Talk in Global Health, How to Revolutionize Without Overstepping, part of our ongoing series of webinars designed to address critical trends, innovative thinking, and thought-provoking issues in global health. I'm Elizabeth Ashbourne, PQMD Director, and I'm thrilled to welcome all of you on behalf of our entire team. For those of you who may not be familiar with PQMD, we are a global alliance of international NGOs and leading healthcare companies united in advancing the role of product donations worldwide. Since 1999, our work has been guided by 6 pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, guidelines, knowledge and innovation, and most recently, climate and health. Our members' work is central to the global effort to achieve universal health care with a focus on creating sustainable access to quality health care in underserved, crisis-affected communities. Before we get started, I just want to give you a few housekeeping items. We encourage you to introduce yourself in the chat by sharing your name and organization. Please also keep your microphones muted throughout the session, but chat box to ask questions and make comments throughout the program, and Hannah and Dylan will be monitoring that. And this session is being recorded and will be posted on PQMD of Practice later this week. So be sure to check it out. And also be sure, if you haven't already signed up for the Community of Practice, sure to do that. And there's going to be a link in the chat shortly to be able to do it. So now it is my pleasure to introduce to you today's keynote speaker, Hannah Cooper Klein. Hannah is co-founder of Cooper Smith and an advisor on the advisory council to PQMD as well. With over 20 years of experience advising governments, the UN, the global health organizations on data and technology, she is an expert in leveraging AI to improve lives in low and middle income countries. Hannah's work has spanned multiple sectors, from development to ethical data management, and she has raised over $30 million to support global health initiatives. Her insights into the transformative potential of health, as well as the accompanying ethical considerations, will be invaluable today. Hannah, we are so grateful for your time and expertise, and that of your colleague, Dylan Green, who you will introduce. And now the floor is yours. Thank you.
Thanks so much, EJ, for the kind introduction. It's really great to be with you here today and to see all of you online. Really appreciate you taking the time, especially during a tumultuous week, I think, for many. So hopefully we'll have some time to delve into some technical areas, explore AI and global health together. I'm delighted to be joined by my colleague, Dylan Green, who's our Director of Research and Science at Cooper Smith. He's been leading on a lot of our AI implementation. He'll be monitoring the chat. So as we go along, please feel free to ask any questions or put any comments in the chat. We'll also try to leave about 15 minutes at the end for questions and discussion. Just given the range of participants, we really wanted to try to hit on some key themes, what AI is, how to think about it, some tips and tricks, but happy to delve into any technical details that you may find interesting as well. So just to get started, here's the overview of our presentation. I'll talk a little bit about who we are as an organization, then try to set the stage for you. Why are we so excited about AI and global health? And then talk about, what is it exactly? What are some ways that you all can think about it? Some considerations, what to watch out for as you're thinking about how best to implement generative AI in your work, some tips and tricks, and then some takeaway conclusions. So just briefly, we're an organization that was started about 10 years ago. Tyler Smith and I come from the State Department. We were working on the PEPFAR program, and he's a health economist by training. I was working on data and analytics, and our interest was really in supporting country governments on better managing and leveraging all of the data that they have available, new data that they haven't thought about before, and new emerging technology to really better manage their healthcare programs and improve health outcomes. So we have a really deep technical bench in terms of data scientists, epidemiologists, AI specialists. We also like to think a lot about the ethical considerations of our work And we do a lot on sort of governance, regulatory standards, and the like when thinking about how to implement some of these new technologies in low resource settings. So our focus, again, is to build data systems that integrate and provide actionable insights for people working at all levels of the health sector. Um, I mentioned our cutting edge analytics. We've been doing some work to predict outbreaks. We did a lot in the COVID response. We also have been doing some generative AI tools that are really compliant for healthcare settings and low resource settings. I just want to flag here that the focus of our work has really been sort of above patient level. So we're not the folks that are, creating Gen AI nurses to interact on phones with patients. We're really thinking about how can we work at the above patient level to help decision makers better make resource allocation or predict outbreaks or the like. So just wanted to flag that distinction. I think a lot of the times when we think about generative AI in the healthcare space, particularly in low income settings, we're seeing a lot of sort of patient level engagements or use of Gen AI. Our focus is really above the patient level, and that's sort of where we come to this work currently. So why are we so excited about AI in global health? Why is there so much buzz? I just wanted to start with this example of what we see today, and I think this example is probably familiar to a lot of you. We have a mother who's at home and suspects that their child may have pneumonia. Her child's health, obviously top priority. She embarks on a minibus or the back of a motorcycle or walks with her child to a health facility. She waits for hours at a crowded clinic. And finally, she sees a healthcare worker who provides an assessment. The healthcare worker, has all of this knowledge available in their training that they use to produce a diagnosis, and said, look, it's not pneumonia. Your child just has a bad cold. You should just go back home and monitor your child. And then the mother and child go back for 3 hours. So, that's at least an 8-hour trip. And there wasn't a medical intervention. The mother wasn't able to work, spent money on transportation, spent a lot of time sort of just getting this diagnosis. And I think what we're imagining or starting to see with AI, what a mother could do at home if her child has pneumonia. She pulls out her smartphone. And yes, I realize that this is also context dependent. And we're seeing some of the applications that are being used on smartphones being developed for dumb phones as well. But the mother interacts with the chatbot. The chatbot provides guidance that no medical intervention is needed, but just rest is what's required for the child. The mother's a little bit hesitant, doesn't like this virtual chatbot and wants to speak to a healthcare provider virtually. The healthcare worker reviews the AI entry, asks a few follow-up questions, and confirms the diagnosis provided by the AI. The mother is still at home and can immediately put the baby to bed. So this was a process that takes less than an hour, ends with the same medical diagnosis, and on top of that, doesn't see the lost wages and time spent on transportation. So, that's just one example. I think there are a lot of ways that we're imagining or predicting that, thanks to AI, we're really on the cusp of a transformative, potentially life-altering revolution in global public health. And, there are a lot of different ways that we're seeing this potentially happening. I'll just talk about 7 briefly here. There's probably a number of different use cases as well, but just to give you a flavor of how we're imagining generative AI can really change the field of global health. So the first one is closing vaccine coverage gaps. So AI can really bring data together in new ways. And by using surveys or satellite data, health records, we can bring all of these different types of data together to really better predict where people do not have access to vaccines and how to target those people much more specifically. And we can make sure that those insights are used to ensure that vaccines are delivered when and where they're most needed. In a second case, thinking about AI and vaccine research and drug discovery, AI is increasingly being used to identify better medicines and vaccines faster. Just to give you a sense, the FDA in 2021 saw over 100 submissions using AI alone. And AI is also being leveraged in vaccine research, particularly in modifying existing vaccines to trigger a strong immune response with better shelf life, which is essential for getting shots in arms in environments with challenging supply chains. Countering antimicrobial resistance, AI and machine learning techniques can analyze data to identify trends missed by traditional statistical methods. And by detecting emerging resistant pathogens and tracking their spread, AI can help public health officials intervene in a timely manner, support research, and create early warning systems. We're also seeing, as I mentioned before, sort of empowering health workers with language models. So AI-powered language models can provide healthcare workers in low-resource settings with real-time information and advice to inform and support their clinical judgments. And these models will use vast amounts of medical knowledge and patient data to improve patient outcomes, even in resource-limited environments. And there are two ways that this can happen, either sort of directly or indirectly. Directly, generative AI chatbots can provide accurate, timely, and very cheap medical advice to clients directly through a phone or a computer. There's also emerging examples in cancer support, mental health, and acute illness management. And indirectly, the AI can support and augment health workers in their day-to-day activities. The lowest hanging fruits, for example, include administrative and management tasks, such as documentation, medical scribing, and scheduling. And AI will also be used as clinical decision support tools, which will assist medical providers and inform their care delivery to patients. Building on this, we're seeing AI being used to digitize and analyze clinical notes with speech to text modules that can automatically transcribe clinical notes. We expect that this would have a dramatic reduction on the paperwork burden that we see, particularly in overstretched clinics in low and middle income countries. And AI and machine learning techniques can also then be applied to those digital notes to classify diseases more accurately and ensure that patients are taking their medication and create personalized training regimes. Also seeing AI being used to better predict local health burdens and behaviors. Again, this has to do with analyzing vast amounts of data and relating them together and helping present that information in ways that can help officials allocate resources efficiently and target health intervention. And then the last piece is really on democratizing data and analysis and interpretation. And a lot of the countries where we work, they struggle to sort of analyze the tons of data that they already have available. And so they turn to consultants like us, for example, and others to integrate data sets and build dashboards and provide other decision support tools. And we're really seeing AI tools that are able to do the data analysis and visualization themselves. So instead of having a consultant create a dashboard or integrate two different data sets, government officials can use natural language to ask an AI chatbot to generate their own dashboard, for example. AIs can also code. And, in a resource restricted environment, which we're finding ourselves now, donors don't like to fund software engineers or that type of digital health support. And so, sorry, I heard a click. I'm just making sure that you can all still hear me.
Yep.
Yeah, okay. Okay, great, thanks. Donors are increasingly reluctant to fund software engineers, but AI can code. So these tools can make engineers far more efficient and increase the government's own capacity to scale and maintain digital services. So, what is it exactly? I mean, we're hearing all of the exciting examples, but let's just take a step back and talk about, what this is. So I think the first thing that's very important to remember is that we're not just talking about a chatbot, and generative AI chatbots have really been the most popular, especially OpenAI's ChatGPT. So I'm just giving a bit of the chronology. We have 2022, ChatGPT sort of first came out, and people weren't really paying attention. There wasn't a ton of excitement about it. But with the additional iterations that came out, and the ability that we had to really interact with these chatbots as if they were human obviously made people, feel very excited. But that's the sort of most prominent example of generative AI, but just to say that, these large language models, they don't have to be a chatbot, but when you put large language models together, or they're used repeatedly, then they make a conversation. And I just wanted to talk a little bit about the many other use cases of large language models and take a bit of a step back to say, like, what actually is a large language model? So I think the most straightforward way to think about this is a large language model is really just a statistical tool within artificial intelligence that analyzes large amounts of text data to predict the probability of a given sequence of words appearing in a sentence. They use these algorithms for sort of predicting the next word, which they call a token in a text. And we really saw sort of these advances over the last couple of years because of the power of graphical processing units that really allowed these types of sort of analyses and processing huge amounts of data very quickly. And so that was really a key development in terms of allowing these large language models to take off and be able to process these amounts of data that are necessary to sort of train these models. The other sort of major revolution was the creation of the transformer architecture, which helped to improve cognition and was really able to retain more information. So this is just an example. It is a large language model is a multi-layer neural network. So you have an input layer, there are these hidden layers of connections, and then the output layer, which is what you will be on the receiving end of. And so how is a large language model trained to do this prediction? Like, how do they know what word is going to be next or how to respond to your question? And I think there's some things just to keep in mind here. One is that the training can be expensive, and the large language model is intensively trained on all of the text it can get its hands on. And the result tends to be a static model. It's general knowledge. So ChatGPT, for instance, is trained on all of the knowledge of the internet, and that's what it knows, and that's how it's been trained to respond and predict what the next word should be in its answer. So it's also, the context is like what it's just heard. It has short-term memory, and it's limited in size depending on the model. And there's not just ChatGPT, there are a number of different models out there, Claude, Mistral 7B, there's a ton out there, but the one that we're most used to has been trained on, all of sort of human knowledge currently on the internet. But after training, the model never changes. And so you need to refill its context with every interaction. And so these models are constantly looking for ways to, further their training and further their knowledge. There's a term that's called embeddings, and that basically helps to improve these large language models. And it's basically a way of pre-processing the data for the large language models. And without these embeddings, the chatbot, for example, so the user interface or what you're seeing, how you interact with them, it relies only on its pre-trained knowledge, and sometimes that can be outdated. In an embeddings model, so how the embeddings pre-processes the data for the large language model, each word or phrase or document is represented as a vector, so a long list of numbers. And these vectors capture meaning based on how the words appear in a large data set. And then similar concepts have a higher correlation between the vectors. So this is sort of a graphical representation of how they think about the relationship, the similarities between the different words that they're seeing and how related they are to each other. So each vector has a certain number, dog has a certain vector or certain string of numbers. It will be close, the numbers will be close to puppy. So the LLM will know that it's similar to puppy, but different than, say, religion, because the numbers in the vector are different from one another. Maybe I'll just pause there for a second. I am not looking at the chat, but just, Dylan, are there anything that we've talked about that you think would be beneficial, benefit from a quick set aside right now? Or should I keep going?
Not for me, but
Okay.
for the audience, there's no questions yet in the chat, but if anyone has
Okay.
anything,
Okay.
let's give them a moment.
Okay, I'll keep going. Another term that I think is really helpful to be aware of, particularly in the global health space when dealing with sensitive data, is something called receiver augmented generation. And so this allows large language models to use information they haven't been trained on. So that's kind of an interesting concept to wrap one's mind around. You think, okay, the LLM has been trained on all information on the internet, but, I have a project that is on HIV prevention in Malawi. We have a number of documents that we share in a Dropbox, but the LLM hasn't been trained on that. So if I was to ask Chat GPT, what's say HIV testing numbers in Blantyre district in Malawi, it would search, perhaps all the internet and see what's out there, but it wouldn't have the latest and greatest data that we have because we're working on this on the ground in Malawi. We have this information in our Dropbox. So this receiver augmented generation allows us to supplement the LLM, say the Chat GPT, or we use another one, but allows it to supplement it with the documents that we have in our repository for our project. And so the receiver takes vectors from the pre-processed data from the embeddings that we just talked about, and then adds in the specialized additional information and then sends it back to the LLM, which then gives me the answer that I need. And I think this is important because one, it allows certain sort of data security and privacy parameters to be put in place. And it's also allows us to be a lot more context specific. A few other key concepts that we hear a lot is temperature. So how random an LLM is. A lower temperature means results will be more similar each time. Another one is top P. So that's how quote unquote creative an LLM is, meaning how many potential next words it looks at when it's making its choice about which word to use in its response. A vector database is a special database that efficiently stores and searches embeddings. And then parameters, those are the number of nodes that the neural network has. And the bigger and more complex it is, the larger. So Mistral 7B, which is an LLM, has 7 billion nodes, for example. So these are things that we think a lot about, and some key considerations when thinking about generative AI, particularly in the global health context. We really want to be aware of ethics, privacy, and justice, and AI really must be deployed with consideration of those details. As we're seeing, and I think a lot of us are aware, the extant guidelines, especially for AI, are very thin, yet there's a hunger for innovation. So here are some ways that we really try to address the ethical and privacy considerations. Oftentimes when we start to think about how to develop out the intervention, we find that concerns over ethics tend to be quite high level and vague. And then we have, groups that are researching and implementing solutions. So what we really try to do is to try to really be very explicit about the risks and benefits of each approach. And we have this sort of some high level principles for how we think about ethics in this. So the first one is relativity. So compared to the status quo, what are the incremental differences in ethical harms and health benefits? And Dylan likes to talk a lot about this, is what do we do in contexts where there currently is no doctor? Would it be better to have an AI or generative AI sort of intervention in that space? Is that better than nothing? So really trying to think through the pros and cons of this. Dylan, I don't know, you have a good example that is better than what I said. Did you just want to chime in there? Not to put you on the spot. Okay, maybe I'll save that for after. The second is perspective. Who stands to benefit, and making sure that they're really centered in the discussions and the assessment. And then the threshold, sort of at what point in the cost benefit curve is it considered worth it? Another thing that we have in place, and a lot of software teams do this already, which is really the concept between blue teaming and red teaming. So we have a blue team that builds the AI solution as best it can. And then we have a red team that is, totally separate and is very divided, is not involved in any of the blue team discussions, and it tries to break the AI solution or cause it to fail. And it's really important that those teams be separate. They don't know each other's tests. And these AI solutions can often look like they're working at first glance, but there can be fundamental flaws in how they are built. So it's really important to have these two different teams. Red teaming can help reveal unknowns or unintended consequences. So, as I mentioned, we're using AI tools to analyze and present data at above patient level. So it may seem minimally risky, but there are some potential risks. So it could reinforce disparities in underlying data. It could potentially reveal criminalized groups. It could inadvertently out individuals by association. So those are the types of things we really try to surface in our red teaming work. I think the other piece to this is that we found there hasn't been a lot of work to date involving community and those affected or who stand to potentially be beneficiaries of this work. So most of the conversations on the ethics of AI have really been concentrated among academics and high income country stakeholders or donors. We think it's really critical to center the voices of people affected by the use of AI and those who stand to risk and benefits in these discussions. And in some of the work that we've done using novel or non-traditional data in the health space before, when we've collected their preferences or opinions about using some of these novel data or technologies in the past, we've had some really surprising opinions and results from those. So just really reinforces the need to engage and get feedback from the people, from the beneficiaries, the people that you're trying to serve, especially when developing these new technologies. Another piece is good governance, obviously, is critical. We should really start by making sure that the countries that we're working in set and enforce policies surrounding privacy and data sharing. And as an example, we do a lot of work in Malawi. We've actually spent a lot of time supporting the government of Malawi, thinking about governance, clearances, standards, policies to make sure that when these new technologies come online, that there is a framework for them to consider how and when to use these new technologies. And a big part of this also involves training and access to expertise to make sure that they're able to legislate and judge AI related issues. And as you can imagine, there's huge demand for this and pretty significant gaps at the moment. Again, to sort of reinforce that point, in Africa especially, there's a lot of work to be made for governance of AI. And in a recent survey of 54 countries, not one of them had dedicated AI legislation. So this obviously is a huge gap. So just, to sum up some takeaways, we think it's really important to be specific in your description of the ethical and privacy concerns. Think through the potential unintended consequences, respect the limitations of the status quo, and listen to the community that you're trying to serve. We recognize that governance is sorely lacking, but we really want to ultimately ensure that civil society and other groups can successfully interrogate AI safety. So just a couple of tips and tricks to leave you all with. Just as a reminder, not everything is a chatbot. Users can interact with AI in many different ways. You could have an AI that's invisible to the user and just looks like a normal website, normal user interface. Chatbots are very open-ended and they can lead to some unexpected behaviors and risks. I think we've all seen the New York Times article about the journalist that had, an AI girlfriend trying to convince him to leave his wife. So, that's out there. And also to consider that, a chatbot might be natural for some use cases, but not for others. So just, context is key here. Also, most solutions use multiple models or not just one. And just a flag, it's important to ask questions to understand, what models are being used, how is it being deployed. that retrieving data from a large document store is a separate model than the LLM used for the chat. So, again, don't be afraid to ask questions to understand what's sort of behind or what's feeding into the development of these models. And the other reminder is not every task needs a sophisticated model. Different models have different costs and strengths. Another thing that we think is very important is that the user experience and user interface is really critical. That on the user interface, that you can be clear what your generative AI model is doing and where it's being used. For instance, we are developing a chatbot that interrogates documents and provides answers to the user, and it interrogates our project documents. And if we say, we want information on X, Y, and Z, the chatbot will show on the user interface exactly which documents it's pulling the information from. And you can click on the document and it will highlight the passage that it is pulling the information from. So there are ways so that the user can really know what the source is and how this information is being generated to provide the answers. Also, you can flag safety or bias concerns. I think you see that also in ChatGPT, for example, where it says, this chatbot can make mistakes. So, there are ways to flag that upfront. In places where WhatsApp is popular and cheap, chatbots can be an excellent interface to data as well. So, but there's lots of considerations that should go into, how you use Gen AI for your use case. So just a couple of conclusions. As we said at the top, Gen AI represents a tremendous opportunity for knowledge access and generation. A lot of effort goes into the fine details of making it work for a particular use case. It's not the right solution for every circumstance, and deep knowledge of models and their trade-offs are crucial for responsible deployment. So I think we have some time left. So I'd love to hear questions, comments, discussions. I'm going to stop sharing my screen so I can see you all as well and look at what's happening in the chat. So thanks so much for your time. I really appreciate it.
Thanks, Hannah. That was excellent. I feel like I've learned so much. Processing all of that information, not as quickly as the chat GPT, but processing it all. And I'm going to just take just the liberty of asking you maybe the first question. And apologies, this question is probably going to just show my lack of knowledge in this space more than anything. But just sort of wondering what your thoughts are on sort of energy consumption and energy needs and environmental impact that I feel like we hear, just sort of about the data servers that need to be set up, and then also the sort of discussions between whether things should be cloud or whether things should be in a data server, and what the privacy implications are. So kind of two questions, I think, rolled into one there.
Yeah, those are great questions. And I also think very relevant. There was just exactly this latest model from China called DeepSeek, which showed that they were able to, process and sort of generate insights using a lot less energy and compute power than, some of these other models. So I think there's a lot to be seen and tested out in terms of that. But I think, we're seeing sort of the answers to some of these questions evolve in real time. In terms of the local hosting versus the cloud, I mean, this is something that we've talked a lot about as an organization. In the countries that we work, particularly with the healthcare data, there's so much reticence to using the cloud for storing the data for many, many very valid reasons. But I mean, in order to have enough sort of compute available to process and use generative AI well, the cloud will have to be used. And so the question that we're really interested in is there an opportunity for governments, particularly in low resource settings, to come together and talk about when have they granted exceptions to using the cloud in certain situations? So for example, we saw with the COVID-19 response in Malawi, the government granted us permission to use cloud to help them with their COVID response because we were processing a large amount of data. We were using aggregate anonymized call detail records as a proxy for population density and migration, so that the government could really target tests and vaccines to where people were and where they needed it the most. So because it was an emergency response situation, we were granted an exception. I think there are probably other use cases, especially as, you know, there's so much potential demand for Gen AI, where we'll see governments wanting to grant similar exceptions. But I think it's really important for them to come together to talk about what, you know, an appropriate regulatory framework might be, that African countries are comfortable with, and that makes, you know, allows them to really be in control and drive this discussion. Dylan, I think you might want to chime in maybe on DeepSeek or the cloud privacy versus local data hosting. I mean, there's another piece in terms of privacy and safety and security of data storage in cloud versus local hosting. I mean, that tends to become a fairly political discussion, honestly. But you know, I think folks in the technology space, you know, everybody agrees that storing in the cloud is the safest way. It's just, you know, because you see servers on the back of motorbikes, you know, they're in unsecured rooms. There isn't always power to, you know, keep the servers in an air conditioned spot. There's a lot of considerations there. But that being said, you know, there isn't always an in-depth understanding of the cloud and what that means and where the data are stored. And the US has really set an example about, you know, having physical PII health data on the ground in country in the US. And a lot of the governments that we work with say that they want something similar. So sorry, that was a bit of a long-winded piece, but there's a lot of discussions in different dimensions to those questions. Dylan, I don't know if you have anything to add there.
I mean, really briefly, and there are a lot of questions coming in through the chat as well, so excited to take all of that. Yeah, on the energy front, I think obviously this is a concern for many. I think overall, though, we're going to be seeing pretty tremendous improvements in efficiency. And, you know, these are the frontier models that we've been dealing with in the last couple of years or so. There are going to be really big improvements in overall utilization and optimization. So beyond that, I think there are a lot of trade-offs to consider. Like right now, we're just thinking about, oh, the environmental cost of asking a silly question or having AI generate a funny photo or something like that. But when it comes to, I think, health use cases, one would have to argue that the potential health benefits and welfare benefits to especially marginalized populations is probably worth the marginal environmental costs, and we will have to figure that out. But it's definitely I think on an improving track. In terms of the data hosting, Hannah, I think you captured it well. You know, by and large, in low income settings and throughout Africa, there is like a in-country priority for many health data. You know, obviously over the last 20 or 30 years, we've seen Africa continually leapfrog in terms of its technological advancements with, say, like skipping over landlines for phone use and going straight to mobile phone technology. We would really like to see that happen with AI as well, as long as it's done reasonably and ethically and is leading to good outcomes. And essentially, as Hannah mentioned, cloud is going to be critical for that. Now, obviously, in the near term, we would be reliant on largely Western and US-based tech companies to do that hosting. But there is a world in the next 3 to 5 years where serious donor investment could be placed in having homegrown African cloud services throughout the continent that could provide perhaps more reasonable support for countries like that. So there's just a couple of additional thoughts, but let's turn to the chat because there's a lot here.
The first one is on, I think, misinformation or disinformation, and how are AIs taking into account those, and are they building tools to prioritize certain types of information sources found online? I mean, I think I would just say that from our perspective, this is where using the RAG model that I talked about, the receiver augmented generation, is helpful. So it's basically taking advantage of these, these LLMs that have been trained to interact with you as as another person, I would say. So they're trained to go through all of your data that you want them to go through. You can limit what they look at and have them generate responses on a really specific set of data. So they're not just pulling from all of the internet. They are, analyzing and exploring all of the data or all of the documentation that you choose. So there is an ability to sort of set those parameters for you, and thereby like limiting some of the misinformation or disinformation. That being said, I mean, in terms of how those companies are interacting with, search engines and all of the information that's out there, I don't know that they're sort of flagging or tagging anything specific in terms of misinformation. You can find that on a Google search anyway. So I don't know, Dylan, if you're aware of any tools or tips or technologies that are out there to try to minimize that.
Well, I think there are two considerations here when it comes to misinformation, and not even just AI, but obviously any web-based technology. One is just the source data. So you could have an issue where an LLM is trained on a lot of data, and part of it is potentially inaccurate or could be deemed as misinformation. So whenever you ask a question related to that topic, it goes and fetches it, and then you're returned with, what's effectively a wrong reflection of reality, right? Alternatively, it could be that all of those things are fine, and the LLM could actually retrieve like accurate and true information. But on the tech firm and like chatbot management side, there's like filters and censorship. So that's some of the things that we have potentially been seeing with some of the service providers. It's not that the LLM itself is biased, but there's actually like a layer over the chatbot that's filtering out certain pieces of information which they may not want users to access. So those are your two levers at play. Obviously, on like the latter side of things, it's kind of simpler in that one can think critically and transparently about what those things are that are being filtered out. And there are a lot of watchdogs and people who think really critically about that. Upstream of that, when it comes to the information and management, I mean, ultimately it's a human problem. Like we need to, at some point, like we can't technologically solve this just by better training a large language model. Both we as users need to be able to like identify when there are potentially concerning results being returned to us by Google or a large language model. And we essentially need to solve it from the bottom up. I don't think there are really top-down solutions to managing misinformation that way, especially at this scale and where we are with web and AI.
There's a question about respiratory disease at the start of the presentation, and what's the process for developing models for detecting and diagnosing other disease states. I'm going to let you handle that one, Dylan.
Yeah, I think there are probably a few different ways this could come into play. I mean, one of the biggest ones, and actually we've been seeing this long before there were large language models out in the wild for many to use, was like visual AI. And so you could look at, say, an X-ray scan of a patient and diagnose tuberculosis or various other respiratory diseases. So there's that visual component, which has been around again for several years and has only been probably enhanced. I mean, every journal, every issue seems to have some sort of visual appraisal of patients, especially even in low income settings where experts, say radiologists or medical professionals to judge those X-ray scans are not readily available. So that's one. On the other side of things is more from the symptom and clinical characteristics perspective. So you can imagine either, as Hannah mentioned earlier, engaging with a chatbot to say, like, these are my symptoms, this is what I'm experiencing, and it would potentially triage you or provide you with greater clinical information about like seeking care or what your potential issue might be. And the extent to which it's able to do that is maybe reliant on access to some of your personal clinical records or something like that. But there's a whole slew of options there from a sort of symptom and clinical presentation perspective. Finally, like maybe a third option is just in better understanding data and data patterns. So if you think about electronic health records and all the clinical and demographic and social data that's stored in there, LLMs and machine learning more specifically is often used to predict outcomes. So suppose you are someone who has like an ear infection or upper respiratory tract infection, and you're trying to predict whether or not that will develop into like invasive pneumococcal disease or something more severe. There could be potential patterns in clinical data that could be gleaned to, again, triage people into like higher or lower risk groups for more aggressive follow-up or clinical engagement.
The next one is a good one. It's the frontier models are being trained on high income country patient data. Are there any thoughts on how we can ensure AI solutions are effective and equitable for LMIC populations with different disease burdens and genetics? That's also one for you, Dylan.
Yeah, I think this one is really tricky, and it kind of goes back to a question we were talking about earlier with kind of cloud and data stewardship. You know, on one hand, we obviously would want LLMs and models more generally to be context appropriate, trained on data locally where appropriate. I think on the other hand, that also means like data are flowing by and large to these like Western or global tech companies that then have all that information and can be using it for all sorts of ways. So I think we need to come up with some sort of strategy where we're thinking about sharing data so that the people in those settings are getting better services, but that there's not some potential like predatory relationship or misuse of those data, which would be like a non-starter for these governments to even share. So there's a little bit of a carrot and a stick here probably, where we should try and figure out like what would the regulatory framework be for sharing clinical data on HIV patients, to give a very specific example, and make sure that those data then aren't sold to some other third party for, you know, some other benevolent or malevolent purpose, right? Like we just want to avoid that. So I think that's tricky. And perhaps in the next like 3 to 5 years, we could again think about those local cloud and model options that are available. But at least like right now in the immediate term, it seems like the only option would be to like share those data more clearly. One caveat here though is with language. So we do see like a drastic underrepresentation, especially of like African languages and dialogues. And this is again something we've been working with in Malawi with Chichewa. And so there could be better relationships between, say, like medical universities, which have a lot of what we would call like corpus, like data on medical terminology, instructions, etc., in local languages that could be shared. And that's like a lot less sensitive, right? So it doesn't really involve individual patient level information or things like that, but it could really improve ability for people in low income settings and throughout Africa, say, to engage with these models in like a more reliable way in a language they feel comfortable with. So that's like maybe an exception or a middle ground, something we should be working on in the near term to like really improve LLMs in that way. I'm seeing Deb is asking about the materials and case studies. You know, one thing that I did want to point out is that PATH has recently started this community of practice for large language models and global health and equity. It's rather nascent, but I think we can share the information for that. And they're always looking for people to join. They have routine check-ins and people share kind of case studies and things that they're working on and talk about many of the issues that we're talking about in the chat here in a practical way. I think by the end of all of this, there's some expectation there will be like repositories and articles and things like that. I think ultimately things are like moving so quickly in this space, it is really, really difficult to like understand today what's going on, what's out there, what's being done, and what's being done well. Because unfortunately, because of the nature of AI and its relationship with tech, there's just like so much hype and excitement, and it's a little bit difficult to see the forest of the trees and sort the wheat from the chaff and understand like what's actually good here. I think, you know, our standards need to be things that are scaled reasonably, that are being monitored well to like be truly having positive effects, and ideally have some sort of tie to sustainability or government ownership so that we know that these aren't just like donor or, you know, private sector supported projects that are not going to live beyond their project lifespan. So but let me do a little more thinking, and there probably are a few resources that we can dig up on case studies for AI use in global health. In terms of the training materials for applying AI, there are tons. They are highly technical. So like if students or people are able to access GitHub and are proficient in coding, there's definitely a ton of stuff out there. And then the other option is always to use AI to help develop your own products. So these things are also trained on all of the coding repositories that are publicly available out there and can readily try and whip up some code for you. So even if you're struggling with your own analysis for your own trial or cohort study or something like that, it's a valuable resource to do that as well.
Yeah, the openness to developing standards for AI development and use, and what level would those standards be developed? Yeah, I think we've seen a lot of initiatives and groups that are trying to think about this and develop this, including WHO and elsewhere. There are a number of, I would say, mushrooming coalitions in this space that are focused on developing guidance. I think Dylan and I tend to think about how can guidance be maximally useful when we were considering very specific use cases and contexts on the ground. So for instance, like what may work for an above patient level generative AI engagement in Blantyre district in Malawi may be very different than what you would need in Burkina Faso at the national level as they're trying to think about you know, primary healthcare. So I think, you know, that's the kind of complexity around setting up some of these global standards and guidance. And we have seen there's a group called Health AI. There's this PATH community of practice on large language models that was set up with the Gates Foundation. We've seen a number of them sort of pop up and then sort of go, I think, defunct or quiet. So I think there's definitely an appetite out there. The challenge, I also would say, just talking to other groups working in this space, is that there tends to be a lot of excitement and very little funding. So everybody wants to know more. Everybody wants, you know, some sort of chatbot to be developed. Very few folks are actually, or funders are actually funding it. So it's a bit, or they're funding like very tiny, small pilot projects as well. So I think, you know, it feels like we're in the early days of digital, which digital health, which EJ and I remember well from when we worked in that space over 10, 15 years ago. I don't know, Dylan, you probably have other things to add there.
Yeah, one more thing I think just to touch on is you know, we're dealing with a situation right now where like a country like Malawi has been well placed, and we've had some success there because they have this really robust digital health division within the Ministry of Health. There's like kind of a whole system and scaffolding for clearly adopting or thinking about AI use in healthcare, right? In country settings where there exists like really no digital health division or infrastructure or something like that, you're really going to be starting from the bottom up. So like if you already don't have standards for data sharing and interoperability, it's like going to be really hard to get to a place where you're able to do something with AI. So probably not just standards, but also thinking about like roadmaps and maturity, like, you know, Kenya and South Africa and, you know, maybe Rwanda are dealing, in Ghana, maybe dealing with these things differently than like DRC or Mozambique or something like that. So there's probably also a need for like better appraisal. Hannah touched on some of that in her presentation. And by and large, there like are emerging standards for AI use or like documenting AI use in research. But I think whenever we make that transition from, okay, we've developed an AI tool, it seems to work in the lab or in like a research setting, now we want to like scale it up and monitor it. There really are just like so few examples, if any at all, to base those sorts of standards on. So I think we're going to be getting there really quickly, and there's going to be a lot of appetite for figuring out like, we've got these tools, we're really eager to use them and scale them up, but we need to do so responsibly and make sure we're monitoring these things well. So
there's a question about recent studies that show the LLMs alone outperforming LLMs in doctors, and reasons why or implications for AI use in clinical settings.
this one I think is interesting, and I mean, there's probably some medical professionals on the line, so yeah, I'll speak carefully. But I mean, I think one thing to just consider is there are a wide distribution of performance, capability, demeanor. You know, there's not like a modal doctor or nurse that like is clearly representative of every interaction that a person will have with a clinical interaction. So, but an AI, on the other hand, is like a representative modal, or maybe even like better than modal doctor or nurse in this instance. So I think a lot of these things are based on distribution. So obviously there are many doctors who would still outperform LLMs. We're talking about things on average, right? So there will be some instances or situations where an LLM could outperform a doctor. And, you know, we're also dealing with things that don't necessarily have the same constraints as say a clinician in the real world. On the other hand, we are seeing an emergence and recognition that there is a lot of value that is intangible that clinicians are also gleaning from a client, like real client patient interaction. So a lot of these studies that maybe demonstrate that a LLM is outperforming a real doctor is maybe a little bit lab based. It's here's a clinical study or some characteristics on a patient, what's going on with them, how would you deal with this? I think time will tell if in like a real world interaction with a patient in the wild, whether LLMs are able to glean things like, oh, wow, you look like you're really struggling, or you're maybe having a little bit of depression, or like actually those sorts of things that a well-trained physician is able to do whenever they're in the room with a patient and like get to underlying issues, maybe things that are beyond just the lab and physical exam characteristics. So we haven't gotten there yet. That's like far in the future, perhaps, or maybe not so far, depending on how things advance. But those are some of the things we should be thinking about practically when it comes to performance in those settings. Yeah.
Just really wanted to thank both of you for an excellent presentation and such thoughtful responses to this influx of questions. Just to let everyone know, any questions that weren't answered, we'll be able to take them to the community of practice and answer them online. And also, Hannah has given us a great sneak peek for one of our sessions for our Global Health Policy Forum, which is going to be in London from April 29th to May 1st. She's going to be chairing our tech session, which is Scaling Innovation, Real World Impacts of AI and Technology in Global Health. So this is just sort of a window of more to come, but really wanted to thank Hannah and Dylan for just so much amazing information and really helping us to learn more about this space. And thank you everybody for joining us, and we look forward to seeing you at the next Pillar Talk. If you have any last minute questions, we'll keep the chat open for a few more minutes so we can share those with them later and respond to them in the community of practice. Thanks again, everybody.
Thanks so much. Thanks for having us. We really appreciate it.
The
Great to be here.
engagement. Bye, y'all.
Yeah, thanks.
Great.
Bye. Thanks.
Thank you.
Thanks.